Okay, today on this podcast, I am joined with Danielle Hairston. She is a psychiatrist, physician, program director, and a CNL fellowship trained psychiatrist at Howard University. She's one of the youngest program directors. She's African American, Black American, and she is an advocate. She's also a part of the APA, the head of the Black Caucus. And I'm really excited to have you on and just create a conversation around some of the recent events that have been going on. I wanted to create a dialogue and kind of see from your perspective and from a psychiatrist perspective and from, someone in leadership as well in psychiatry, how you're hit by the recent events. And I've read a couple of the things that you've been quoted in the news saying. So yeah, tell me a little bit about how you feel as a Black American going through this as a psychiatrist with the death of George Floyd and this just really unique time that we're in.
So it's twofold, I guess, because as a psychiatrist, we go into training. We want to help people cope with trauma, treat depression, anxiety, things like that, deal with post-traumatic stress disorder, PTSD. But at the same time, aside from me being a psychiatrist and a program director, I'm a Black person. So my identity is as a Black person first, a Black person in the United States of America who is witnessing this trauma, who's witnessing vicariously the killing of people who look like me and people who look like my family members. And it's a lot. It's a lot to process. I think that what I'm noticing is in medicine, as a leader, as an expert in trauma and mental health and anxiety, depression, whatever you want to call it, I think that people reach out to you. A lot of non-Black people reach out and say, oh, I just don't know what I could do to help. And I think that they don't even process that we as Black psychiatrists, and myself as a Black psychiatrist, is really trying to process my own thing, deal as a person, as a Black person in the United States. So, or in the world, in the universe, who's watching this trauma, who's watching the repeated killing and violence towards people who look like me, who has to worry about weaponized privilege, who has to worry about if I'm just going outside living my life, or my boyfriend is outside living his life, or my godson, that someone will call the police on you for just being a person who's jogging, who's sleeping, who's eating.
Yeah. Yeah. And I know that it can be a lot to have to talk about it, have people ask you all these questions, and then through your own sort of experiential life, have to as well sort of see these images, see these pictures. I mean, like when I saw the image of George Floyd, like that was like a painful thing for me to see. And I can only imagine for you to see that, and for you to, it's not like this is the first time you've seen it. It's like a repeating of prior things that you've seen, of prior things that you've experienced.
Right. So let's be clear that seeing Black people as victims of crime, as race-based hate, of race-based killings, of lynchings, that's not new. So that's not new for Black Americans. That's not new for anyone who's Black in this world. It goes back to, Emmett Till, going back to having images of lynchings throughout the South and even some places in the North, things like that. So it's not new, but it's just that it keeps happening. And it's just traumatizing to keep seeing this over and over and over. And I think it's traumatizing as a human. So for me to hear you say, like, it's traumatizing for you, I think it should be traumatizing for us all in this country. But then when you can visualize yourself going through this, or someone that you love and care about, or just as a human, as a Black person who feels for the Black community, knowing that this is what we're going through, it's distressing. And it's not something that you want to see. And I can say that outside of movies and TV, like television shows, I've never seen a white person be killed.
Mm.
a white person jogging down the street and be murdered, like I just saw for Ahmaud Arbery. I think that one is the one that really just was so hard to just digest and just process, because he was literally just running down the street and then you just see him on TV, no warning, no, this might be, or on social media, no warning, this might be distressing to your viewers, or, whatever it is, the warning it is. But I just see him as someone who could be myself, or someone who could be my brother and be shot and killed. And that's a lot.
Yeah. And I think you're entitled to the full range of emotions in that, and I know it's a lot probably even coming on and talking about this, but I think it's an important conversation to have with the psychiatry community, with the psychotherapists that listen to this.
I agree. And I appreciate that you took the initiative. Like, this is what I like to see and I like to hear. Like, actually saying this is something that needs to be talked about. We need to have this discussion. So it is difficult, but I appreciate the opportunity. And I really appreciate that you're doing this so that others in the psych, whether it's psychiatry or psychology community, can really be aware that this is something that is affecting their patients, their colleagues, and the communities that they treat.
Yeah, one of the Black residents that we had, we kind of checked in before a psychotherapy clinic this week. It's a clinic that I lead. And she said, guys, I'm very aware that I'm the only Black resident here. You guys may not be aware that I'm the only Black resident, but I'm aware that I'm the only Black resident. And I'm also aware that right now you guys are talking about this, and I'm glad you're talking about this, and I'm glad you guys are paying attention. But I just want you guys to know that a couple weeks from now, when this is all died down, I'm still living in this life. Right. And it really hit me, and it was really kind of like, okay, I know we're having this conversation right now, but I really want to dig into some books in the coming months and maybe have you come back on in another time when this has died down to continue the conversation, to continue to put it out in front of people's minds.
That's great. I have many books and ideas. Even if we want to talk about a couple of them today as some homework to get prepared for the future, that's fine also.
Yeah, that would be good. That would be really good. Maybe towards the end, I'll write down a couple of them, and then anyone who listens to this can write them down as well and be reading them, and then we'll have a second conversation about that. I think that would be really meaningful.
Okay.
So I think one of the questions I have is, if you were talking to someone who's not Black and you were giving them input on how to help them understand Black racial trauma or help someone who's Black with their mental health issues, I'm curious about how you would coach them, what you would say.
Well, just like you talk about other traumas, and it's difficult, it's difficult to talk about abuse, right? It's difficult for people to talk about sometimes even substance use, but you really just have to do it. You have to ask your patient, is this something that's affecting you? Is this something that you're worried about? Is this something you're experiencing? Or what are you experiencing? Or if they say, what's going on is really disturbing to me, I'm not able to take this, don't say, okay, check, and go to the next box and ask them about any side effects of their medications or how their sleep is, because they're trying to tell you how their sleep is. They're trying to tell you about their symptoms, and you as a psychiatrist or psychotherapist need to explore that further. You have to be comfortable with getting uncomfortable. You have to just make it happen. You have to ask, you have to be deliberate, even if it's hard for you, even if it's uncomfortable for you, because you want to help the patients, correct? So you have to do the work.
Do you think this is the uncomfortability? Do you think it's part of? There's this statistic that I was looking at recently that Black people get half as much psychiatric care as people of other races, white people. I don't know if you have something more accurate than that.
Half as much? I've read 1/3 as much.
Okay. hey, correct me. I'm looking at some data. You know the data much better than I do.
But
So
for
one third as much.
1 in 3 Black people
Okay.
get the same mental health access or care as non-Black people or as white people. So yeah, that has to do with the level of discomfort. I think that we have to really acknowledge the historical context, that we are not without history. This country doesn't have a perfect history or a nice, pleasant history when we think about race relations. So we have to consider that one of one of my colleagues said, like, oh, this has been going on for what, like 100 years or 200 years? No, like 400 years of Black people being enslaved in this country. So you have to think about that for generations, generational trauma that people have experienced. So when you're talking to a patient who is what, in their 50s or 60s, or 70s, they could have experienced rioting and uprising in the civil rights movement, and they could have had hoses sprayed on them or dogs attacking them when they were just trying to express their feelings about their rights to just live their lives. There are people whose family members, some who are still alive, were involved in the Tuskegee experiment. So things like that are not foreign. Like, it's not, oh, that's so far away. Like, we now live in an environment that's free of racism. So I think that it's important to understand the historical context and understand that this is generations in the making. So it's not that, oh, I'm just talking to you here. I think maybe the psychodynamic people can really discuss and understand, like, this is not just what's happening here and now between me and you in this therapeutic, what we hope to be an alliance, but this goes back further. So there's that lack of, there's just a cultural mistrust. There's also a lack of diversity in psychiatry. There are not, in psychiatry and medicine, period, there are not many Black psychiatrists. There are not many Black psychologists. There are not many Black physicians, period.
Yeah. Okay. So I want to backtrack on what I said, because in no way do I think that the discomfort is the reason why there's 1/3 of people getting care. I think that there is lots of levels of bias and things. And so I want to, like, ask you, like, what do you think are some of those reasons for that 1/3 number? Like, what is keeping, is it the doctors choosing? Is it the insurance?
There's a myriad of reasons why there's a limited access. Many reasons that go from economic reasons, housing, residential reasons, just based on access to care, like where you live and how close you are to a therapist or a psychiatrist or a hospital. So if I have a patient who lives in one ward of DC, they have to take 2 buses and a train to get to see me. However, if they're late or they can't make it, I have to reschedule them.
Yeah.
Or they can't be seen. And then they'll have to decide, should they use their money to pay for the bus fare or for their copay for their medications, or to have a meal for their family next week. So there's that, the access to care. There's also, like, as I was saying, there's a lack of diversity and there's a cultural mistrust. There's a cultural mistrust of psychiatrists, but there's a cultural mistrust for physicians, period, because we are not without history. And when you've seen for generations your people being treated a different way, or even if you haven't, some people experience racial profiling or weaponization of privilege, and they've never seen that before. They've grown up in a completely, higher socioeconomic status neighborhood, and they never expected that they would get pulled over for being a Black male adult driving through their neighborhood, but that's where we are.
Yeah, I saw a clip of a very tall Black male who was kind of pulled over by these 2 policemen, in this sort of situation that we're in right now. And he pulled out his FBI badge, and the policemen were like, "Oh, so very surprised."
Right. What if he didn't have his badge? Or what if he wasn't an FBI officer? It's like your freedom pass. So I could pull out my hospital badge, right? And say, hello guys, I'm a doctor. Or a student might be able to pull out their badge and say, oh, I'm a student at Harvard. I'm a student at Yale. Don't call the police on me for sleeping here in the lobby of the dorm. I actually go here. But they didn't know that they would experience that. But we have those quote unquote freedom cards, like I as a physician or a student, and as you just brought up the example of an FBI officer. However, what if you don't have your ID? What if you can't prove that, oh, I pay my rent, oh, I have a job, or I'm employed? Like, why do I have to prove that I'm a human and deserve to not be profiled?
Okay. Yeah, it's horrible. It's horrible.
There are things that we can do to attack, to treat, and combat this.
Yeah. So what are some of those things that you feel like for the APA, like what are some of the things that you were pushing for within psychiatry, or what are some of the things that you get excited about? Like, okay, these are the places of progress that I would like to see happen.
I like when people make statements of solidarity, like we are here together, but I only like those statements if they come with actions behind them. So if you say that you are supporting Black people and that you care about Black people and this is terrible, okay, let me see some programming about this. I want to see something about the APA presents, which they already are going to, by the way.
Okay.
Racism in psychiatry, and really talks about how racism is a public health issue, how racism is traumatic to people. Like, I want to see that. I want to see that you are telling your members that this is something that your patients and your colleagues are going through. So I want to see action like that. I also want to see some diversity in these committees, in your executive boards, in your recruitment committees.
Mm-hmm.
Like, show me. Don't just say we stand here, but be deliberate. Promote people to these positions. Sponsor people in these positions. Fund these things. Put your money, your funds, and your efforts behind diversity initiatives. You want to talk about them? You want to write about them? Do them.
Mm-hmm. Yeah, 100%. Totally makes sense. And I'm glad to give you this platform to say those things, or say the things that you're excited about. And I'm curious, like what do you think we can do to get more medical students going into psychiatry, or what can we black medical students, or get more Black medical students? What are some things there that you feel like we could do?
As far as medical students, I think that, so I'm in a unique place, Howard being a HBCU, one of the oldest with the medical school, its own medical school, and we are deliberate in our searching, in our recruiting of medical students. Like, we are looking for medical students who say that they are here to serve the underserved patient population and that they want to promote diversity and come back and serve these communities when they're finished their training. And I think that that's not something that should be unique to Howard. That's something that all programs, if you genuinely care about this, all medical schools should say that, like, should take initiative to include diversity and equity in their recruitment and in their education. And as far as getting medical school students to go towards choose psychiatry as a specialty, there is a stigma, of course, about psychiatry and medicine that we are all aware of, no matter what color we are. We have attendings who tell my residents when they're rotating on internal medicine, like, you need to switch. You're too good for psychiatry, or you're too smart for psychiatry. So there's that stigma that we have to fight. And then there's, a mistrust about psychiatry in the Black community, about whether or not you should talk about your problems, whether or not you should take medication, things like that. So I think that we really have to work on reaching out, making pipeline programs, reaching out to undergrad, do things, make yourself visible, do
Mm-hmm.
programs with them. The APA does that. The APA has a pipeline with undergrad programs and to help them. It's to get into medical school, period, but we hope that they might be aligned with psychiatry, things like that. But that shouldn't just be the APA. That should be any university. That should be any hospital.
Yeah, that's good. So if you're listening to this and you are undergraduate, Black student who wants to get into medical school, send me an email and I will make you a co-author of our next articles or next episodes that we do together. Okay. And we'll put you first author, get you something for your CV.
Yes, that's what I'm talking about. Sponsorship.
Yeah. Cause I really think like a lot of it's just access to mentors, maybe. When you only have 3%, is it 3% of psychiatrists are Black? Is that the correct number? Or that's what your friend told me. Who put us in contact.
Sometimes 4%. I see like 2.7% consistently. So I go with 3%. That's fine.
Yeah. Okay. So which books should I be reading, or which books would you recommend for a therapist or a psychiatrist to read? And we'll make a list of like the top maybe 3. Let's go with 3. Okay,
3?
Go for it. You just tell me, tell me which ones.
Okay, I think that period for a psychiatrist or a psychologist, a book called Why Are All the Black Kids Sitting Together in the Cafeteria and Other Conversations About Race by Beverly Daniel Tatum is a good book. Also, Racism in Psychiatry. That's actually a book that I had the opportunity to work on with Morgan Medlock, and it really goes through many different levels of how you can address racism, how you can help in therapy, how you can help with treatment, how you can help with assessment, and really discusses everything from food insecurity to lack of housing. So that's a good one. Also, another one that's a little bit older, but one that I liked from residency is called Black Pain. We Just Look Like We're Not Hurting, and that's by Terry Williams. And I think that's a really good example of a Black woman who describes her experience in going through depression, anxiety, insomnia, and the difficulties with seeking help just on many levels. So I think that's a good one. And the last one is not necessarily for Black people, but the last one is one called The Body Keeps the Score. Can't remember the author right now.
That one, I have that one by Bessel van der Kolk. Bessel van der Kolk? Yeah, he's fantastic. Well, I feel like there's so much more for us to get to, and I hope that we'll have you back on. Maybe I'll get through one book. Little known fact, I'm not very fast reader, so maybe we'll do one book at a time. Out of all these books, which one would you say is like the first one to read?
It's a tie. I gotta say it's a tie.
Okay.
In Psychiatry with Medlock and the Why Are All the Black Kids Sitting Together in the Cafeteria. Between those two, they're
okay. Perfect.
I also use Audible because I'm very slow with reading as well.
Yeah, I can do Audible a lot faster because
while I'm walking. But...
Yep. Well, hey, thank you so much for coming on. Thank you so much for giving up a little bit of your time this Friday afternoon. And
it was great. Went well, in my opinion.
Yeah, and we will be excited to have you back on and continue this conversation. Much needed conversation.
Okay, I was ready with your questions about why do fewer Black Americans get SSRIs?
Oh man, do you want to give that one real quick? Probably because does depression show up differently, or do the symptoms that they present with,
sometimes symptoms present differently in African American, not just African American, but Latinx, also Asian patient populations with a lot more somatic symptoms and not so much outright saying, I am depressed, my mood is low. And if people really aren't able to really finesse and pick through and understand those symptoms and how to prevent, then depression and mood symptoms are constantly missed in the Black patient population. And they're often overly diagnosed or misdiagnosed with primary psychotic disorders like schizophrenia when they are missing completely mood and trauma. So there's that. But they are not offered the same new antidepressants or not offered are not referred to therapy. We see the same thing with substance use and the use of buprenorphine and Suboxone. JAMA had an article about that last year about how they are not referred to these programs and medications. So it's a combination of the access and also just implicit and sometimes explicit bias.
Yeah, I've seen a couple Black Americans that come in with what looks very much like trauma to me, and they've been put on like antipsychotics, right. And not given the correct referrals to therapy. So I think that's a really good thing to point out. Well, we will have a lot to discuss in the future. Jot anything down that you would like to say in the future, and we'll include it. And thanks for coming on today.
Thank you.